Perfect. Okay, so I'll just bring up my slides and welcome everybody tonight. So it's May. Before you know it, it'll be June and we'll all be together. But welcome to the JVS Online Journal Club. Tonight we have our two host institutions, which is Stanford University and OHSU, Oregon Health and Science University. And we're thrilled to have two really great papers that we're going to be talking about: impact of thoracic endovascular aortic repair timing on outcomes after uncomplicated type B aortic dissection in the SVS Vascular Quality Initiative post-approval project for dissection. Dr. Adam Beck is here as the author from that article. And then use of direct acting oral anticoagulants associated with improved survival and bypass patency compared with warfarin after infrageniculate bypasses. And we have Dr. Ebertson, also Dr. Kolvard, and Dr. Kashyap I saw popped in as well. The two host institutions this evening, Stanford, Dr. Shipra Arya, who is the Chief of Vascular at the Palo Alto VA, is our faculty member, and Dr. Shanaz Dosavoy, who is their fourth-year vascular integrated resident. From OHSU, Dr. Leo Dabb, who is an assistant professor of surgery, and then Dr. Kelsey Hira, who is their first-year fellow. Again, we have our author guests, which is such a delight that we have authors that are here with us so that they can answer questions and really help us to understand some of the nuances of their research. Dr. Ben Kolvard, who is the medical director and assistant professor of surgery at Case Western Reserve University. And then his fourth-year resident, Dr. David Eberts, who's also, he's a general surgery resident applying for vascular surgery at Case Western. Dr. Adam Beck, who is hiding in a brewery closet, but is from the University of Alabama as a professor and division chief at UAB. We have our two moderators from the editorial board of the JVS, Dr. Alina Quiroga, who is an associate professor of surgery. She's a program director of the vascular surgery residency and fellowship at the University of Washington, and Dr. Bjorn Suko, who is also associate professor and associate program director at Dartmouth Hitchcock Medical Center. So for tonight, please stay muted if you can. If you have questions, we'll prompt you to put them into the chat. Our moderators will be directing those questions to our authors to get those answered. We are taking a break with the online JVS Journal Club for June. We'll be seeing everybody in DC at VAM, but in July we'll start back up, and we have our two host institutions in July, which are Dr. Matt Smeds at St. Louis University and Dr. Ali Aburama from Charleston Area Medical Center. So with that, I will stop sharing my screen and we will turn it over to Dr. Arya.
Thank you, Dr. Humphreys. Let me see. I hope you guys are seeing the right screen.
It looks perfect.
Perfect. All right. So thank you so much for inviting us to discuss the paper from Dr. Beck and group for the May JVS Online Journal Club. As you mentioned, Shanaz Dosavoy, our vascular surgery PGY4, will be discussing the paper, and I'll provide a background. Let's see. Okay, so we'll be discussing the impact of TVAR repair timing on outcomes after uncomplicated type B aortic dissection using the SVS VQI post-approval data for dissection. The TVAR dissection project, this post-approval study, was funded by SVS PSO, and the author conflicts of interest are listed here. As you all know, TVAR and complicated type B aortic dissection, there is now much data to support that TVAR is the mainstay for therapy for complicated dissections, which includes presentation with malperfusion, rapid expansion, or aneurysmal degeneration of the aortic wall, impending rupture, pain, and refractory hypertension. However, controversy exists in the use of TVAR for uncomplicated acute type B aortic dissection. There is limited data to support the benefit of intervention versus medical management, but intervention is thought to be helpful for potentially facilitating a favorable aortic remodeling and prevent aneurysmal degeneration and late rupture, and hopefully improve mortality long-term. Because with medical management, the long-term survival is pretty poor. It's about 60 to 80% based on reports at 5 years and 40 to 45% at 10 years with medical therapy alone. There have been prior trials on uncomplicated type aortic dissection. The INSTEAD trial is the seminal trial that was done and published in Circulation in 2009, randomizing patients to TEVAR versus medical management. But this was at 14-day time point after the occurrence of the dissection. Overall survival was comparable between the two groups, 89% for TEVAR and 96% for medical therapy. But favorable aortic remodeling was seen, 91% for TEVAR versus 19% for medical therapy. The long-term follow-up of this trial did not show difference in all-cause mortality, but did show lower aorta-specific mortality for TEVAR and lower risk of progression with TEVAR. Retrospective studies and meta-analyses have had mixed results. The last meta-analysis, I think published in 2020, included observational and RCT data, and reported similar rates for inpatient mortality and early reintervention. While best medical therapy was associated with lower risk of early stroke, TEVAR was associated with a lower risk of late all-cause and aorta-related mortality. The ABSORB trial was the latest trial done on this topic, but it had low enrollment and was underpowered. So since 2020, SVS and STS developed guidelines that have reported new reporting standards for type B dissection, which you see summarized here. And for type A dissections, the entry tear of zone 0 just requires classification of the distal extent of the dissection, whereas for type B dissection, the proximal and distal extent of the zones can be identifying, therefore providing standardized nomenclature so that treatment for type B aortic dissections and type A dissections could be reported in a standardized fashion in trials and observational studies. They also established onset of symptoms, whether it is hyperacute presentation, less than 24 hours, acute as 1 to 14 days, subacute 15 to 90 days, and chronic greater than 90 days. And I think this is an advance going forward, as all reporting for treatment for dissections will follow this reporting standards. So the SVS, PSO, FDA, and industry sponsors have collaborated on this database that the paper today is based on. It is an ongoing prospective project designed to evaluate TEVAR for real-world outcomes. There's enhanced data collection and long-term follow-up and evaluation of both early and long-term outcomes. So Dr. Dosaboy will now take on to go over the methods and the results of the trial.
Great. Thank you so much, Dr. Arya, and good evening, everyone. And thank you to the JVS and Dr. Beck, studies lead author, for the opportunity to present their article. So as Dr. Arya mentioned and reviewed so nicely for us, TEVAR's role in uncomplicated type B dissection, or TBAD, has really been controversial with limited data on the benefit of intervention versus medical management. As well, the optimal timing for TEVAR is also uncertain. So this study's objective was to determine the impact of TEVAR timing for uncomplicated TBAD on early and late outcomes using the VQI TEVAR post-approval study data. So this was a retrospective analysis of a prospectively maintained registry data. And as Dr. Arya described, this SVS VQI TEVAR dissection post-approval project really began in 2013 and collects 5 years of enhanced data on centers who are already participating in the VQI TEVAR registry. We should note that only Gore and Medtronic patients were included in this current study we're discussing, as the patients receiving Cook devices are still in active enrollment. This study included uncomplicated TBAD only. That was defined as those without rupture or malperfusion. And importantly, uncomplicated included both those that were entered as uncomplicated in the VQI registry, as well as those with available high-risk features, including rapid expansion, aneurysm, refractory pain, or refractory hypertension as the indication for why the TEVAR was performed. Emergent cases were excluded from this study. The cohort was then stratified into 3 groups based on the timing of repair after dissection, according to the SVS STS guidelines. And those were less than 24 hours or day 0, hyperacute, 1 to 14 days or acute, and then 15 to 90 days or subacute. The authors did propose a secondary analysis, breaking down the acute category into 1 to 7 versus 8 to 14 days, and comparing that to the subacute phase, which was 15 to 90 days. The primary endpoints in this study were postoperative mortality, in-hospital complications, and reinterventions. The secondary endpoints included spinal cord ischemia, stroke, reintervention, both in hospital and long-term, and additional postoperative complications, as you can see here. Moving on to the results, there were a total of 606 patients enrolled, and 206 of those had uncomplicated TVAD. Of those, there were 8 patients that had TVAR within 24 hours, 121 patients that were treated within 1 to 14 days, and 77 patients treated in the 15 to 90 day groups. Overall, the groups were similar with some notable differences. There was a higher rate of transfers from the outside hospitals in the day 0 and 1 to 14 day groups. There was a higher rate of preoperative ACE inhibitor use in the day 1 to 14 and 15 to 90 groups. There was a higher rate of aortic surgery in the day 0 and 15 to 90 day groups. A higher rate of dissection proximal to zone 3 in the day 0 group, and a higher rate of urgent repairs in the day 0 group, with 100% of patients designated as urgent. Regarding indication, the refractory pain was the most common indication for repair across all 3 timing groups. And specific high-risk features as designated by the SVS and STS differed, with a higher rate of refractory hypertension in the day 1 to 14 group and a higher rate of aneurysm in the day 0 group. We also want to note that only 4 patients in the total cohort had a designation of uncomplicated upon the initial entry into the VQI. And then I'd also like to highlight that there were 2 patients that required a therapeutic lumbar drain post-operatively. Both patients were in the 15 to 90 day group, and this will be important when we discuss the multivariable analysis. Overall, outcomes were similar between the groups, with a few exceptions. There were significantly higher rates of postoperative stroke and CHF, both at 12.5%, and renal ischemia at 25% in the day 0 group. Unadjusted 30-day mortality did not differ significantly. It was 0% in day 0 versus 3.3% in the day 1 to 14 group, and 5.2% in the day 15 to 90 groups. 1-year mortality appeared to increase with time to repair, with 0% in day 0, 8% in day 1 to 14, and 18% in day 15 to 90, but this result also did not reach statistical significance. On multivariable analysis, only the need for having a postoperative therapeutic lumbar drain, as was shown in Table 1, was found to be predictive of postoperative mortality with a hazard ratio of 7.6. Interestingly, no high-risk features were found to be predictive of postoperative mortality. Now looking at their Kaplan-Meier analysis, here in Figure 1 in the top left, this compares the survival amongst the 3 timing groups, as well as a greater than 90-day or chronic group. And there's a notable separation in the groups, with highest survival appearing in the day 0 group, followed by greater than 90 days, then 1 to 14 days, and then the 15 to 90 day group, but there was no statistically significant difference in these curves. In Figure 2, which is here in the bottom left, this was a secondary analysis where they excluded the day 0 group and then compared the day 1 to 14 and day 15 to 90 groups. Here again, we see a separation of the curves, but this was not statistically significant. In Figure 3, here in the top right, this looked at reintervention after TVAR, and this also showed a notable separation in the curves for 1 to 14 days and 15 to 90 days. But again, this was not statistically significant. And finally, in figure 4 here in the bottom right, this was again a secondary analysis where they compared the 1 to 14 day group, which was then further divided into 1 to 7 days and 8 to 14 days. And these two groups were compared. While this was also not statistically significant, there was a trend to higher survival with a p-value just under 0.06 in the trend to higher survival in the 1 to 7 day group. In terms of long-term follow-up, this is from the supplementary tables they provided. It demonstrates that there was no difference between groups with respect to aortic enlargement, rupture, or reintervention out to 3 years. So to summarize, there was no statistically significant difference in survival or reintervention between any of the 3 TVAR timing groups. The hyperacute or day 0 group did have a higher rate of postoperative complications. However, the small number of patients in this group, only 8, really limited any valid statistical comparison. Also, of these patients in the hyperacute group that were repaired within 24 hours, they likely represent a high-risk subgroup, and we may want to consider them in that light. There was also a trend to improved survival noted in the acute 1 to 14 days versus the subacute 15 to 90 day phases. This was the secondary analysis, though outcomes did not differ for early mortality, postoperative complications, or 1-year survival between these two groups. Some of the limitations that the authors discuss, the VQI, is really trying to represent real world data. And so that has some of its inherent limitations, including that follow-up can be challenging, made even more challenging in dissection patients specifically, and that the VQI is a self-reported registry data, as we know, and so there's a potential for selection bias for TVAR versus medical management, and that the data accuracy really cannot be determined or verified. So in conclusion, the authors sort of state that longer term follow-up is still needed both for this project and to compare with the INSTEAD XL trial result that Dr. Arya mentioned, which found that there was lower aortic specific mortality at 5 years. It also underscores that really the mixed results of both the prior studies, both RCTs and VQI based, really emphasize the need for a future randomized controlled trial for optimal treatment and timing of uncomplicated TVAD, including medical therapy as a potential control group. Finally, we thought we would just kick off the discussion with a few of our own questions for the authors. So one was, what was the average follow-up for the entire study cohort? And how should we think about what long-term follow-up really means in patients with aortic dissection? 2, should we instead be thinking of this cohort as uncomplicated with high-risk features, since only 4 patients were truly designated as uncomplicated upon entry into the VQI? And finally, a significant portion of patients had a proximal zone involvement of their dissection above zone 3. And so we can infer that this means it was likely a zone 2 entry tear and required coverage of the subclavian. So do we know how many adjunctive procedures were performed, and could this perhaps contribute to some of the higher perioperative complication rate we see in the day 0 group? With that, I'll hand it over for further discussion, and thanks again for the opportunity to present.
Very nicely done. Just if you could just leave your slide up there, that would help me, because
does that work? Thanks.
Yes,
Dr.
that's
Beck.
great. Thank you. Both of you did a really great job outlining this, and I thank you guys for presenting my paper. I really appreciate it. This project is now 10 years into it. We started this, it was really 9 years, but we started it retrospectively back to 2013, and it was approved in 2014 by the FDA. So it's been ongoing for quite some time now. The average follow-up for the study cohort, I wish you'd sent me these before, because I can't remember that off the top of my head, but I will tell you that we have our follow-up out to 3 years rivals the pivotal studies for Medtronic and Gore as far as what our ability to follow those patients. So although this is a real world study, it's not exactly real world, because there are actually PSO SVS PSO staff that are dedicated to this project and really follow up the patients pretty closely and communicate with the centers. And the loss of patients really is related to the real world nature of it. It's just difficult. Dissection patients are notoriously difficult to get them to follow up. So I don't remember the average follow-up, but I will tell you that we have almost 100% follow-up at a year. So we really were able to get pretty good follow-up, at least in the short term. I think that long term means at least 5 years in these patients. I think that's been pretty well borne out in the Instead XL. That was where you started to really see a differentiation in how patients do. And what we're trying to prevent in these uncomplicated patients, for the most part, is aneurysmal degeneration of their aorta distal to the stent graft. And we're not usually treating something like an aneurysm in the stented segment necessarily. So if they truly are uncomplicated, I think that to answer that question, you need to be looking at 5-year follow-up, and we're going to continue to follow these patients out. As you mentioned, we're still enrolling the Cook dissection patients. Their device was just approved a couple of years ago, so that's gonna take us a little bit longer to get those patients completely enrolled and to get longer follow-up for all of those as well. The uncomplicated patients with high-risk features, the SVS STS guidelines actually came out, as you know, I think we published that in 2020. And so that came out long after we really set out to do this project. So all of those things were not really defined a priori in this project. And so we actually designed the registry for this project, the dissection portion of the registry around this project. So I think there's probably high-risk features that we're just not capturing in the VQI, and that's why there's, those 8 patients that were treated on day 0. It's pretty rare for people to treat a patient on day 0 without there being something that's pushing them to do it, And so, despite that, they look uncomplicated in the registry, but there was probably something that made them do that. And my inclination actually was to leave those patients out when we initially did the study, but we felt like we needed to include them because they fit our inclusion and exclusion criteria. And then your question about proximal zone 0 to zone 3, I apologize, I don't remember the number of adjunctive procedures. We do have those data. We have all of the data around carotid subclavian bypass or any arch debranching or arch stenting. That all of that was actually relatively rare because of the way we set out to do the project. So the carotid subclavians were not rare. Anything proximal to that was relatively rare in the data set, and it did not fall out as a predictor of poor outcome. I think those patients in the first 8 days are just a different, they're just a different animal than the rest of the patients. Did I answer all your questions? Yeah. Okay. Great.
Thank you, Adam.
Let me jump in real quick here. Thank you.
Thank you.
Thank you to the Stanford group for presenting this paper. Doctors Aria and Dasaboy, very well done. And I'm really happy to have Dr. Beck here tonight to help answer the questions already. If anybody else online has questions, please put them in the chat and I'll go comb through them and pick a couple out. But for you, Dr. Beck, and maybe also somebody else in the group, let me just take it back one step, right? We've been taught that we should avoid urgent TEVAR for the uncomplicated type B aortic dissection, that there is a penalty and we should delay it into the subacute phase or maybe 90 days or so. What I'm reading here is, I agree, we ignore those 8 patients who were done truly on day 0, but everybody else, there does not seem to be a penalty for doing an earlier TEVAR. And perhaps that's the message that we're taking away, because really your cohort are people who were selected to be operated. We don't really have the counterfactual here of those who were medically treated. And I'm going to point out that right after your article, the companion article in this month's JVS actually addresses the medical therapy versus intervention in a similar cohort. But let me just ask you first, Dr. Beck, would you agree that perhaps based on what you've shown us here, we can move away from that idea that there's a penalty for doing an early TEVAR, and perhaps that might be the better way to go?
Yes, with some caveats. This is not a prospective trial. These patients weren't chosen and randomized into these groups. And so what I would say, in well-chosen patients, yes, if you think that the patient can get a TEVAR that is relatively uncomplicated. They've got good anatomy. Perhaps it's funny because one of my former fellows just was texting back and forth with me this morning of angsting about whether he should wait an additional 5 days to TVAR a patient he knew that he wanted to TVAR. And so my answer to that was, is if you've got a good proximal landing zone in normal parallel aorta, especially, and maybe a lower risk of retrograde dissection, then, and all the patient is doing is sitting in the hospital waiting for that 14-day mark, yes, absolutely, I think I would do a TVAR on that patient.
That's very helpful. Thank you. And just to pinpoint real quick, the companion article I mentioned highlights that patients who were medically treated rather than intervene for uncomplicated type B dissections, they had a penalty of more readmissions without a deficit in terms of mortality. So taking these two articles sort of in conjunction, is that enough data now to guide our decision making, or would you say we still need a randomized trial? In other words, if I have uncomplicated patients with high risk features, is this enough to say we should just TVAR all of them? Or do we need a randomized trial? And if so, how do we best get that underway?
Well, there's a randomized trial that just got funded by the NIH for this question. So hopefully we still have a question to answer, but and we are going to participate in that trial. The patient that I see most commonly, I would say that I feel like I need to stent are the ones that are on a lot of blood pressure medications, kind of intermittently having chest pain. It's not that bad, but they're they're not going to follow up appropriately. And there's always that question of, is it better for them to not follow up and get a TVAR, or not follow up and not get a TVAR? I don't know. But I do still think there are some unanswered questions, and I think a randomized trial is a good idea. But I don't have a lot of trepidation about doing a TVAR on day 6 versus day 15 in a well-chosen patient if I feel like they need a TVAR.
That's helpful. To piggyback on that, Dr. Arya posted in the chat the question whether we know if improved AD trial will define uncomplicated type B aortic dissections as the post-approval study, or will it exclude high-risk features? Do you have any insight to that, or anybody else perhaps?
I think that they're going to include patients with high-risk features if the study still looks like it looked the last time I saw it, but I don't know that with 100% certainty.
I'm pretty sure there's a webinar coming up on it, or there's a meeting at VAM too. So
yeah, and Dr. Kashyap just posted that there's a systematic review on this topic right now in press at the European Journal of Vascular and Endovascular Surgery. So I might defer the group to also look into that. And then Dr. Humphreys had a question about the main indication here being intractable pain. If there's a way to determine how well blood pressure was controlled, i.e. how good was the medical management of these patients in the cohort? I know that may be hard in the VQI analysis, but do you have comments on that?
I think that's an excellent question. The short answer is no. And actually that's probably where the randomized trial will be able to answer a question that we just can't do here. And I think, the refractory pain thing is always interesting because dissections hurt. It hurts when your aorta dissects, and patients get really anxious, and then they get hypertensive, and then they get more pain. And so it's really important to treat all of those things and treat them with anxiolytics and pain medication and get their blood pressure down, and then see how they look. We still, we don't TVAR everybody at UAB by any stretch of the imagination. We still medically manage them up front, and a majority get medically managed, I think. But I think that's a great question. That's what really needs to be answered in that trial.
That was very insightful. Thank you. I think we should move on to the next paper for time's sake, but thank you again to the Stanford group and you, Dr. Beck, for being here and presenting this very important topic. Thank you.
Thanks, everybody.
Dr. Dab, you want to take it away?
Okay, thank you for the opportunity to participate tonight. I'm going to introduce the topic of antithrombotic therapy after lower extremity bypass. We chose this paper on DOACs versus warfarin after infrageniculate bypass. as many of you, we treat lots of patients with lower extremity bypass, and we like them to stay open and are looking for best practices and how to do so. So when we consider lower extremity bypass principles, we often talk about inflow, outflow, and conduit. In the case of femoral popliteal or infrageniculate bypasses, this implies good aortoiliac inflow, good tibial outflow, and ideally a good conduit such as single segment saphenous vein versus PTFE, but should we also be considering post-operative antithrombotic therapy as part of our principles. This study from the University of Florida, published in JVS in '98, was a small, often referred to randomized trial of 56 patients deemed at high risk of graft failure based on the criteria of either marginal vein, poor arterial runoff, or prior history of graft failure after infrainguinal bypass. All these patients received 325 aspirin and then were randomized to aspirin alone versus aspirin and a warfarin regimen. Notable outcomes were postoperative hematoma in the warfarin group, 32% versus 3.7 in aspirin alone. And cumulative limb salvage in the warfarin group was 81% versus 31% in the aspirin group, and 3-year primary patency, 74% in the warfarin group versus 51% in the aspirin alone group, as demonstrated in their Kaplan-Meier curve here. This study from the Dutch bypass oral anticoagulant or aspirin or BOA study group was a multi-center randomized open trial after infrainguinal bypass surgery. They randomized 2,690 patients to oral anticoagulants with a fairly aggressive INR of 3 to 4.5 versus aspirin, 80 milligrams daily. Interestingly, they found no overall advantage to either treatment to prevent graft occlusion. But interestingly, oral anticoagulation had better results in the vein grafts, and aspirin had better results in the non-venous grafts or prosthetic grafts. And as expected, major bleeding episodes was higher, almost twofold, in the warfarin group versus the aspirin group. So kind of mixed results. This study of antiplatelet therapy as a form of antithrombotic therapy after bypass, the CASPAR trial out of the UK, published in 2010, was a prospective multi-center study, randomized, double-blind, placebo-controlled of patients after below-knee artery bypass, randomized to aspirin versus aspirin plus clopidogrel. They used a composite efficacy endpoint, was their primary endpoint of combined graft occlusion, revascularization, above ankle amputation, or death. And they found, seen here in the Kaplan-Meier curve, no significant difference in clopidogrel group versus the aspirin alone group. But they did suggest, when they broke it down, that the aspirin plus clopidogrel confers some benefits in patients with prosthetic grafts without significantly increasing major bleeding risk. So what does the Society for Vascular Surgery say about this? So there's clinical practice guidelines that are pertinent to this, published recently in 2015, the guidelines on peripheral arterial disease, primarily in asymptomatic and claudicants, recommended in patients, claudicants undergoing lower extremity bypass, be it a venous or prosthetic conduit. They suggest treatment with antiplatelet therapy, be it aspirin, clopidogrel, or both. This was a grade 2 recommendation with a level of evidence at B. And then more recently, the global guidelines on CLTI, clinical practice guideline published in 2019. There was still limited evidence to support a specific antithrombotic regimen in patients after vein bypass for CLTI, but still recommend a continued single antiplatelet medication in terms of long-term management of patients with PAD. So based on these kind of mixed evidence and limited guidelines to apply to our patients. We found this study interesting, and our fellow Dr. Kelsey Hirai will present the paper. She's a first-year fellow, has been with us after graduating her general surgery residency at Stony Brook. Go ahead.
Thank you, Dr. Dobb. I'll share my screen right now. And I want to thank everyone for the opportunity to present here today, and Dr. Eberts, Dr. Colbert, and Dr. Kashup for being here to discuss the article. I'm going to start by presenting a little bit of the introduction. So the 1-year patency rate for lower extremity bypass for peripheral arterial disease ranges from between 40 and 88%. In general, antiplatelets are routinely used postoperatively and are recommended to reduce MIs, strokes, and vascular death in patients with PAD. However, as Dr. Dobb just mentioned, the benefits of anticoagulation are not as well established. Anticoagulation has been used selectively after lower extremity bypass for patients with prosthetic conduit, compromised vein bypass, poor outflow, or thrombophilia. Previously, warfarin was the standard for anticoagulation, but newer direct-acting oral anticoagulants have become more popular. And this paper aimed to compare the outcomes of patients discharged on warfarin or DOACs after infrageniculate bypass. So they started with a retrospective cohort analysis of the VQI database from 2007 to 2020. They included patients who had undergone an infrageniculate bypass and included only those with femoral inflow and outflow to the below-knee popliteal artery or a more distal target. They also only included those who were not on prior anticoagulation or those who the indication for the procedure was claudication, rest pain, or tissue loss. They then looked at those who were discharged on anticoagulation, either warfarin or a DOAC. Specifically, they also excluded those with concurrent endovascular procedures, those whose indication for the bypass was acute limb ischemia. The primary endpoint were overall survival, primary patency, amputation-free survival, and freedom from major adverse limb events at 2 years postoperatively. Amputations included any amputation above the ankle on the treated limb. Major adverse limb events included untreated loss of patency, repeat intervention on the index arterial segment, or any amputation above the ankle on the treated limb, independent of mortality. The primary predictor was the anticoagulation that they prescribed at discharge, either warfarin or a DOAC. The group comparisons were made with a 2-sample t-test or chi-square test of association, and the time to event endpoints were analyzed with Kaplan-Meier curves with the log rank test. They also used a Cox proportional hazard regression to generate hazard ratios with adjustments for baseline demographics between the different groups. They found a total of 2,786 patients, 1,889 on warfarin and 897 on DOACs. They found that the warfarin group was more likely to be associated with white patients, those with Medicaid or Medicare insurance, those who are dialysis dependent with renal failure, those with urgent or emergent presentation, and those who use a vein conduit. This reflects the prohibitive costs of DOACs, as well as the use of warfarin more commonly in patients with ESRD. The indications for bypass, preoperative aspirin use, ABIs, inflow source, and concurrent endarterectomy, and the use of vein cuffs were similar between the 2 different groups. Overall, they found that DOACs had a primary endpoints that were much better than warfarin. They found that there are overall higher rates of survival for the DOAC group compared to warfarin, starting within the first year. Within the first year, primary patency was also better in the DOAC group than in the warfarin group. Around the first year, let me do this. Amputation-free survival as well as freedom from major adverse limb events were approximately the same. However, after 1 year, the DOACs did much better than warfarin. And although there's no mechanism for the reason why DOACs are superior to warfarin, the study does reflect that similar findings from other disease processes, such as atrial fibrillation and venous thromboembolisms. They also use multivariate Cox regression analysis of the entire cohort to determine variables associated with their primary endpoint. They found that in addition to DOAC use, increased age and dialysis dependence were associated with decreased survival, loss of primary patency, amputation, and risk of major adverse limb events. They found that the variables with decreased survival also included Medicare insurance, nursing home or homelessness, congestive heart failure, COPD, and below-the-knee popliteal artery bypasses. Variables associated with decreased patency included prosthetic grafts and more than one vein segment used. Variables associated with amputation included Medicare insurance, nursing home or homelessness, urgent procedure, and the use of prosthetic graft or multiple vein segments. And the use of multiple vein segments was also associated with major adverse limb events. They cited a few limitations, which included first that this was a retrospective study, so that there was a significant loss to follow-up after the index hospitalization and compliance with the medications was unknown. They also cited that they could not determine the specific indication for prescribing the anticoagulation to these patients postoperatively. However, they attempted to mitigate this risk by excluding those with atrial fibrillation preoperatively, as well as those with acute embolic or thrombotic limb ischemia, and those who are on preoperative anticoagulation. And lastly, one of the limitations was that they did not know the types, the dosages, and the durations of the DOAC that was prescribed. So they weren't able to tell between rivaroxaban 2.5 BID versus full dose therapeutic anticoagulation. So in conclusion, this is a retrospective review of the VQI database from 2007 to 2020 of infrageniculate bypasses comparing warfarin to DOACs on discharge. They found that DOACs are superior to warfarin with a lower risk of overall mortality, a lower loss of primary patency, a lower risk of amputation, and a lower risk of major adverse limb events at 2 years. I do have one question, although not on the slide, for the authors of the article. I was wondering if this has changed any of your practice after this, and the dosages specifically of the DOAC that you would use if you did prescribe anticoagulation to your patients.
Thanks, Dr. Hirai and Dr. Daub for your discussion of our paper, and to the organizers, thank you for selecting our paper to be discussed this evening. To your question, I don't think it's necessarily changed my practice. I kind of already use DOACs, mainly for prosthetic bypasses. I actually have been up until now, I've used DAPT for vein bypasses. But this study has kind of, for me, provided a signal that, there might be something to using DOACs more often. And I certainly use it for my high-risk PAD patients, in the outpatient setting, in the low dose form.
Thank you so much to Dr. Daub and Dr. Hirai for presenting. That was great. And I have to say, I'm loving this Davis Stanford OHSU Seattle connection. I do feel a little bad, and I want to thank everybody in other time zones for joining us so late. There are a lot of questions. I do have a lot of questions, and there are already a lot of questions in the chat. And so I want to go first with a question is, especially to Dr. Colbert, you choose 2007 to 2020 as the date for your study. However, dagitarban was approved in 2010 and rivaroxaban in 2011. And I have to recognize at the beginning, we were using it only for atrial fibrillation. And I was very hesitant because there was this kind of feeling that there were not as effective as warfarin for arterial beds. Now we all have changed our practice as another situation. So do you think, first, my question is why you choose those dates? And second, have you seen a trend when you look at the data between the early, I don't know, 2012 to 2014 to maybe 2018 to 2020, and in the utilization of DOACs, and if you think that you will conduct the study right now, it will have the same outcomes?
Yeah, we don't have the data in for the trend in, year by year, what number of patients were on DOACs versus warfarin. I think that's actually something we have in a follow-up project that's ongoing, but I don't have it available for this paper. We wanted to cast a wide net to increase our number of patients. That's why we went back to include, patients who were going back to 2007. These are obviously going to be the Coumadin or warfarin patients. And so that's why we went all the way back to 2007. But unfortunately, I don't have, it would be a great graph to show the trend increasing use of DOACs. So hopefully for the next project, we can include that.
So the next question is kind of a mix of something that I was going to ask you, and Dr. Humphries actually put something similar on the chat. I think that 16% of the patients in total were already in dual antiplatelet therapy before the procedure. And actually most of those were in the patient that ended receiving DOACs at the end. Do you know how many patients were discharged in aspirin plus a DOAC or aspirin and warfarin? And how many patients actually were discharged on the three and dual antiplatelet therapy plus anticoagulation? And do you think that may have any impact in the outcomes?
I think it definitely can have an impact. I think when you're doing a VQI study like this, you can get overwhelmed with the number of possible things to compare. So we wanted to really simplify and keep it as clean as possible by really only looking at the anticoagulants. So we did not focus on whether people were discharged on any certain antiplatelet regimen in terms of our comparison and analysis. But yeah, I do think that there can definitely be an impact of being on a single or dual antiplatelet agent in addition to a DOAC. But at some point you just have to stop the madness in how many things you're going to compare in your VQI study.
And linking to that, I personally almost never put a patient in dual plus anticoagulation. The data of bleeding complications it differs incredibly. We look in the paper, we learn about all-cause death and other outcomes, but there is no mention of bleeding complications or readmission for bleeding. I'm talking about GI bleed or any bleeding related to the anticoagulation. Do you have any data on that? Because that can add, and there is a question in the chat about cost analysis that can also add to the cost of the medication and the treatment.
I agree. That data is, to my knowledge, that's not available. That's not tracked in the VQI. And someone can correct me if I'm wrong, but bleeding complications and readmission for bleeding is not tracked in the VQI, unfortunately. And then is the same with cost data. The main barrier, I think, at least in my practice, is for patients being able to afford a DOAC if I want them to be on that. So when you talk, when people talk about, is this going to change your practice? Well, as much as you can, you're going to use what is an easier medication for your patient to take. But the reality is that, sure, maybe they can afford it for the 3 months that they have a coupon, but then after that, you're basically going to maybe aspirin and Plavix, or, I really hesitate to put people on Coumadin because I just see so many issues with it in terms of, the lab follow-ups. And so unless it's like a prosthetic to tibial bypass and they can't take a DOAC, I may use Coumadin there, but other than that, I'm really not putting anyone on warfarin because of those issues. I'm interested to hear what other people are, how much people are using warfarin nowadays for bypasses.
I do think that at my institution, we have a special kind of situation. We have a very, very good anticoagulation clinic. So it helps a lot. And the cost for us, for DOACs, for most of our patients, I work in a safety net hospital, is almost prohibited, even with a coupon, believe it or not. Warfarin treatment for a month is in the order of the less than $1, in the 25 cents. So it gets very difficult to compare to a DOAC when a patient has to pay out of the pockets. But the issue, there are other multiple factors that are involved, as we said. Dr. Ari asked a question about the outcome, and this will apply to both, but she's asking, without linkage to Medicare, can you rely on measure amputation and measure adverse limb event in VQI? We can use like Social Security database to link mortality. The follow-up on these patients was not complete. So can we really say that this is the final number?
No, I mean, I think Shipra, Dr. Arya, your comment is very, relevant. It's, as with any VQI study, as soon as we get out of the in-hospital period, the data quality starts to drop off. And as soon as we get to the 1-year mark, it takes a nosedive. So, I don't think that this is the type of study that, I want everyone to read it and change your practice because of this. This is a VQI study that is providing a signal that DOACs might have a benefit in lower extremity bypasses. And I think this is a message that we need to go in and do a deeper dive and do some, better quality, higher quality studies on this, because there's, this is providing a signal that there could be a benefit out there for this.
Dr. Kashyap, did you want to contribute?
Yes, thank you very much, and great discussion. And I guess now, after Ben Colvard and my favorite bow tie surgeon, David Eberts, if they say I got to use DOAC, I guess I got to believe them. I've been a little bit of a stick in the mud, despite Voyager and Compass data. But I think the real question, and the question that I think Shipra is getting to, is the comparator nowadays may not be so much warfarin, but really dual pathway inhibition versus DAPT. DOAC aspirin versus aspirin clopidogrel, and that's still a question I think for many of us that remains unanswered. But great discussion. Thank you. I guess I'm going to have to write some more rivaroxaban scripts going forward. Thanks, Ben.
There is one question about the cost effectiveness, and they're asking specifically if we're aware of any cost-effective analysis of warfarin versus DOAC. After I'm not aware of any studies like that, and I wish that showing a study showing that will change what insurance thinks. But I don't know if anybody have any information about any prior studies showing effectiveness for. I'm not even sure for AFib. So one last question I have, two quick questions. One is a very self-serving question. When I see all these results about either dual antiplatelet treatment or anticoagulation for bypasses done for peripheral vascular disease, we see a difference not only on cardiac events, but in major adverse limb events. My question is, what should you do for trauma? And what are you doing? And let's forget about VQI. What are you doing in your practice? What are you doing with your patients for trauma? Are you keeping them are you giving them any extra anticoagulation, or just aspirin, or not even aspirin for healthy young people?
Yeah, I don't know what the right answer is. For most of the lower extremity bypasses that I do for trauma, they're relatively short bypasses compared to what we do for PAD. So I don't, and the other, I think, huge thing is that this is a bypass done for non-atherosclerotic disease process. So these are otherwise, for the most part, normal arteries, unless, an old crusty smoker gets shot in the leg, right? That's rare. I think most of these are short bypasses with normal inflow and outflow arteries, and probably don't need the help of DOACs or a lot of antiplatelet therapy. I do put them on aspirin. I don't know, for 6 months or a year. Honestly, most of them don't come back after that. But I don't think they need it. And I have a small series in my practice of people who have come to me with a trauma bypass from 20 or 30 years ago that remains patent. They take no antiplatelet or anticoagulation. A couple of them just came back for surveillance, and a couple of them have come back with GSV bypass aneurysms. So I don't think occlusion is necessarily their big problem.
I'm happy to hear that, because I do my best to take my aspirin every day. I do actually aspirin for 6 weeks unless I am concerned with a single vessel runoff. That's just my particular practice for young, healthy patients. But I want to be sure that I'm doing the right thing. One last question to close. We're having an amazing discussion. I'm sorry, we're going to go over the hour, but I want to address the question that Dr. Ingorani put in the chat, because I think that this sum up a lot of what we're discussing, and it sums up about the cost effectiveness and other issues. Do we think that there is a selection bias because there are a group of patients that can afford to get DOACs? They have insurance, they can get DOACs. Are the DOACs, or are the whole way that we treat patients that are more privileged in a lot of senses that are showing us this impact, and how will we address that?
Yeah, I think there's the possibility for selection bias, but there were more patients in the DOAC group that were like in nursing homes. Obviously, private insurance was more common for the DOACs. So it's possible that they have, because they can afford a DOAC, that means they're going to be able to afford to come to the doctor. They can get a ride to the doctor, all these things. I mean, the most common reason that someone doesn't show up to my clinic is they couldn't get a ride. I think that definitely there's a possibility that there could be some element of selection bias for higher socioeconomic patients who are receiving these more expensive drugs, having overall better medical care. And that's something that's a problem of our society here.
Yeah. Well, thank you very much, everybody. We didn't go over, we're going to end it just on time. Dr. Quiroga got us right to the end of it with that great question. Thank you to all of our authors, to our moderators. We'll see you in person at VAM, and then we will see you in July back online. So have a great night.
Good night, everyone.
Thank
Thank
you.
you all. Thanks, Misty.